Well, okay. So, Christy, so you were going to ask some questions?
Yeah, I can start there. So,
Okay.
and like I said, this has been a couple weeks now, so bear with me if I can't remember what I was intending with the questions because it's just been kind of a running list as I've been going.
Mhm.
So the first one is really basic and probably not even that important, but on the front page of Med Data Services where it says applications in process,
Uh-huh.
it looks like, and I don't know if this is something I'm supposed to be clearing, if it's something that's supposed to build, but when I first logged in, it was, what the waiting to send, I guess. Is that just something that accumulates until we clear it out? Are we supposed to clear it out? Or is that, what do we do with that?
It's something that you should entirely ignore. And
Okay,
the reason is, so you would use that if you were working at a doctor's office. You would use MedData and see which ones you had not yet mailed out. And
okay,
because we don't ask people to send them back to us anymore, we just are telling them, at least, last I did it, telling them to take it to their physician's office. So I mail it to the patient. I don't log, that I actually mailed it or any of that kind of good stuff. So, like if we look at it, for example, person, like this one. So normally, if you're going to send it to your patient, if you were at the doctor's office, you would be sending it to the patient and logging all of this stuff. Once they received it, you would put the information in here, all of that. And we really just don't do that. It's just not our role.
okay,
It's labor intensive, and in the first year that I did this, I tried to maintain that, and there was just it was so very difficult to get the feedback from the patient, and
okay,
absolutely impossible to get it from the doctor. So we just stopped doing it.
okay. So it's okay if it just builds and builds and builds, just pretend like it's not even there because it's nothing really relevant to what
Yep,
we do.
there you
Okay,
go. Click on
perfect.
that button, it goes away.
Okay. Um, okay, so question number 2,
Uh-huh.
and this is where you're doing the tracking with the medications. So when you're entering it in with the day supply, yeah, if you go to any of those, or like, yeah, add a record
Uh-huh.
and tracking. But my question is, and I guess if when you're doing your examples, I'm gonna really watch how you figure this out because I was getting hung up on a couple of them, but I wasn't clear on how you would handle the day supply for medications that you don't really use on a regular basis.
Mm-hmm.
So like injectables, like an EpiPen or something like that, where you just kind of have it for insurance, but you don't even know if you're going to use it in the year. So would that be the day supply when you're entering it in? Is that a year supply?
Mm-hmm.
Or I mean, you could use it right away and then it would have only been a month's supply, or I wasn't really sure how to use it for something like that.
Well, like for an EpiPen, I think we've always made the assumption that an EpiPen was a single 2-pack, because normally when you do that application, that's just what you get. With a
Right.
single application, which is for a year's worth of an enrollment, you get that 2-pack. So
Okay.
that's all I've ever entered it for. If it's someone who calls you back and says, "Oh, hey, I need this again," well, then maybe we would add it. But there's really not a great way. There's no other baseline other than you get 2 with each application, and if they
Uh-huh.
fall back, you would add it again.
Okay.
But yeah,
So
I always
a
called it
year
a
is
year's
good.
supply.
Okay, that's good. And then, okay, number 3. So, okay, so I'm just trying to make sure that for the AWP calculation, I think this will help me out too when I'm watching you do it
Mm-hmm.
again. But when we're figuring it out, say you help the client get 4 months worth of, free or reduced medication. So when
Uh-huh.
you're doing that calculation, are you calculating it off of the 4 months that they're getting? Or if it's something that they're going to continue using for the year, are you going to assume that they're reapplying?
Mm-hmm.
Or
What's the 4-month thing? Like, is there a
it's just
specific
something
month?
I threw out there. So like maybe they got 3 months worth of it or something like, or 90 days or something like that. Are you only calculating the savings for those 90 days that you helped them out with? Or would you figure like how much time is left in the rest of the year if they're going to Walmart to get it refilled after that?
So a little bit of all of that. So if it's for someone who's on Medicare and their enrollment period is really from whatever period of the year till the end of the year. So if it's from October to December, I'm just counting that time period, because for a Medicare enrollee really only, because that's really all they're enrolling for. When you sign up a Medicare enrollee, it's from who's on Part D. It's only from the date that they apply through the end of the year. If it was someone who was using, you know, I'm assuming they're going to get Medicaid in the next month, but I don't know for sure if they ever do. I'm enrolling them in a program where they can get access to free medication for up to a year. So I'm going to put it in for 365 days is my assumption. I don't know if we're going to actually use that amount or not. You know, the only way that I would do like, oh, it's like a 90-day supply of something is if it's Chantix and they are literally, their doctor's going to say, I'm only going to put you on this for 90 days. Just know you're going to be titrated up and then you're going to be done with it.
Okay, so something that is limited like antibiotics, then use it for that term. Otherwise, assume that it's a year that you're calculating.
Yep.
Or whatever's left in the year where you are.
Yeah, and right. And that's so with Medicare enrollees or for somebody who gets like an exemption, you know, they're not technically eligible for the program, but they are able to get in. Enrollments usually last till the end of the year, and that's it. So.
Okay. And then this is another calculation thing, but I think we'll get into that as you're working through it, or at least I can kind of get a better idea if I'm doing it right. And then, okay, so I remember when we were training a while ago that there was I don't remember for sure, I think a clinic that you preferred for presumptive enrollment for Medicaid.
Yeah.
Is that Care Alliance, or was there a reason that it was Care Alliance that you preferred over the other ones?
It's just, you know, I think in ReferNet, we aren't listing if they do PE, presumptive enrollment.
Right.
But just kind of systematically from being out in the community, the ones that actually did it most frequently, self-reported doing it most frequently, were the Free Clinic, Neighborhood Family Practice, and Care Alliance.
Okay.
So like Neon was hesitant to do them.
Okay.
And that's just kind of that. Everybody else was doing it willy-nilly, wasn't afraid, just was doing it.
Got it. Okay. And then, okay, this is another one from back when we were training. I overheard, I guess I should say, when you were talking to people, you asking them a lot if their card was red, white, and blue.
Yeah.
So that's the Medicare card, right?
Yep.
Yeah. Okay. So were you asking that because a lot of people aren't really sure what they have? Is that something I'm going to run into? Like they don't know if they have Medicare or Medicaid or?
Yes. A lot of people don't know what they've got at all. And the only way for me to really figure out what they had was, okay, because they'll say they have Medicaid,
right?
But they've been on disability for 12 years. And you're like, well, what color is your card? It's red, white, and blue. Okay, so now you've figured out if it's red, white, and blue, and they say, oh yeah, it says Medicare on it. Yeah, that's it. And because unfortunately that population may not also have great reading skills, they may see MED and say Medicaid, even though it clearly says Medicare. So red, white, and blue is a great thing. And then you can figure out what their income is, because they might have Medicaid and Medicare. Okay. So, you know, if their income's under 75% of federal poverty, well, then they may actually have Medicaid too.
Okay. Okay, and this is another thing back from when we were training. So the assistance programs, I remember you saying that some of them, or maybe all of them, I'm not sure which, will only provide assistance when the drug's being used for an approved condition. Is that all of them?
Do you mean the National Copay Foundations?
Was it that? I was trying to remember, because I remember specifically you working with one lady and she was using the drug for something beyond the scope of what the drug was actually approved for.
Right.
And I couldn't remember if it was one of the assistance programs or one of the copay programs or what it was, or how I would find out if that was the case, or if it's across the board that all programs do that, that you have to be within, you know, the approved uses for the drugs.
Generally, almost exclusively, the drug companies themselves they're only able to give medications for that, the FDA approved usages of it. So if it's off label, then they're not going to be able to provide it, because you're using it for something that, well, the Fed said you're not supposed to use it for, so they can't give it to patients then. That's that piece. For the copay foundations, they receive dollars that are earmarked for specific diagnoses. So some of them have a little flexibility, like I think like the Chronic Disease Fund has money that they have set aside for IBS, but they include Crohn's disease in IBS. Okay. So you really have to find out what are you being treated for. Realistically, Needy Meds is probably the easiest way to go around that one, to look up to see what Needy Meds says it's going to be used for, and go from there, and then just call the foundation and say, oh, I'm using it for this. But unfortunately, the patient may or may not really fully understand what they're being treated for, so you kind of take it with a grain of salt, say, okay, well, normally it's used for this. If the foundation says we'll cover it for this, then the patient, either you and the patient, if you don't feel confident in their ability, or you can call and say, okay, this is the scoop, and they'll go from there.
Okay.
They really try to, the foundations, the copay foundations really try to fold in as many people as they can. So if they don't have funding targeted for that diagnosis, then they'll know who does.
Okay.
They're good kids.
Yeah. Okay. Okay, so here's another one, and this is just what is allowable, and this is from another conversation that we had, but I wasn't sure, like, I guess what my limits are in doing this, but basically, is it ever okay to suggest that they ask their doctor about a similar drug that may be less expensive? And it is. Okay, because I wasn't sure if that was like beyond the bounds of what I was able to do with like the whole EpiPen and AubiQ thing was what I was thinking of, where you can get it for free versus paying for whatever the thing was with the EpiPen. So I'm allowed to say, maybe you should see if this version is okay with your doctor, because you can get it for X amount.
Absolutely. That is totally cool to do. What the pharmacists and doctors that I've talked to have said is what they'd really prefer that we not do, and drug company assistants, not providers, but staff, is say, hey, I understand you're using Ventolin, and did you know ProAir is exactly like it? You could probably just switch to that. They don't want you to suggest other meds because it may not be appropriate for that patient. But the long and the short of it is, if you tell someone, hey, did you know Ventolin is pretty much exactly the same as ProAir, the patient can't go out and get it on their own. So the doctor has to prescribe it, and the pharmacist has to fill it. So we wouldn't actually be doing anything. So it's something that I've done for decades.
Okay.
But that's up to you and Finley. Okay.
Okay. And I'm getting near the end here, so we can actually do other things. The last stuff is med data specific stuff, so we may be able to look at it when we're in there. But one of them I noticed when I was doing some of the scenarios that in the manufacturer drop down, once you're in and entering the drug that you help them out with, sometimes I don't see the exact program in there. Like it was the one example that I actually wrote down, but it happened one more time after that, was Lilly Cares, and for some reason only Lilly Cares Oncology came up, but it wasn't oncology that I was actually working with in that particular scenario, and I didn't write down what it was, but
okay, so you were going through, like, I'm going to create an application for somebody, and it was
Yep.
You
and the
went
add
to
to
the
tracking.
manufacturer?
Yep, in there.
Okay, so why wouldn't you just start with the drug name?
Well, I didn't go through this screen. I guess I'm going through the wrong screen here, but because I went to tracking system and then add record to tracking. Is that not the best way to do it?
Well, if you're generating an application, and I know using Needy Meds is easy. I suspect maybe that's what you were doing, is you pull the application up maybe in Needy Meds, and then you were logging it in MedData. Yeah, because I mean, Needy Meds is great for lots of things, but if you're looking for a medication, even if it's something you've already pulled out of Needy Meds, just for sake of tracking purposes, to me it's easier to just say, oh, it's Humalog and it's in here, add it, and then go up and just add everything in here.
Okay.
Maybe there's a different way that you can do that and, bastardize it in some way. Okay, cool. But I would just do it here.
Okay.
And then once you've already...
Go back to that screen you were just on, actually.
What was that?
Can you go back to that screen you were just on?
This
that
one?
Yeah. Okay, well, where'd the dosage go when you...
Here?
There, yes. Okay, so I want to make sure that I am looking at how they're recording this correctly. Okay, so there's 100 milliliters of vial, and then 10 vials. Is that, or what's the times 10 here?
Sometimes, honestly, it's hard to tell in MedData because they do it. They haven't always got it right.
Okay, because that times 10 was throwing me. So, like, this to me looks like it should be 100 milliliter vials, right? Okay, and that times 10 was really throwing me off on the drugs when I was trying to figure stuff out from here.
I think it's 100 milliliters, but I mean, the vial itself, I think, it's 10 milliliters. But it's 100 units per milliliter, so it's 10 milliliters.
Okay.
Does that make math sense?
Yes, yep, now it does. It was, because I was using their AWP table too, and some of the stuff that they have in there and how they have it configured was really throwing me for a loop. So, yeah, okay.
Yeah, sometimes it is straight up just weird, and it's hard to work backwards sometimes. Like, I'm sure there's some reason for why they entered it that way. You can always email them, like Dawn at MedData. I think her contact information was in this sheet somewhere, and say, what's up with this? And she's pretty responsive. They'll get back to you right away, like, minutes. And or you can just go back in and say, okay, I'm going to go to, whether it's like GoodRx, or you're going to the other website to get the price for the medication, and then just add it directly in, and save it that way, if that makes English sense. Like, if this training person, let's see how this one was entered. So the quantity is 5 quick pens for a 30-day supply. Okay, that makes pretty good sense. How much does it cost? $524. Okay, so if we wanted to make that a year's worth.
See, there's the Lilly Cares Oncology. That was actually it. So that was the drop down where I tried to find something else for Lilly Cares. So it's just under Eli Lilly instead of Lilly Cares then in that scenario, I guess.
Well, that's kind of goofy, isn't it?
Yeah, right. So that's why I was really thrown, because this was the page where I've been entering everything in.
Oh, okay, yeah. So, yeah, they have it here under Eli Lilly Cares PAP.
Okay.
Isn't that nuts?
And then while we're on this page, that actually brings up another question that I have, because sometimes when I try and put the diagnosis in, it makes, and this might just be a MedData thing, I don't know, now it's doing it, of course it's doing it now, but it would just make the whole bar blue to where I couldn't actually, like, I was able to enter in the first one, but if they had multiple things that they had to have entered in after the first one, the bar would just become blue and there would be no drop down that would show where I could actually select a diagnosis.
Okay, here's a nuts question. So when you go to the patient profile, you have to add add all the diagnoses here. So if the diagnosis doesn't exist here, you're not going to be able to select it once you open one of these up.
Okay,
So
it should be in there.
okay, so you feel pretty confident that you had already added it, and
Yeah.
unfortunately, this stupid thing where you add a new record and then you have to type it in and then hit insert in order for it to save, and then you have to come back over here. I think sometimes the screen might need to be refreshed in order to have it selectable.
Okay. I mean, it was even with the same diagnosis for some of them. It just, for some reason, it might have been my program. I tried restarting it, and it was something with just making the blue bar. It might just be a fluke with the days that I was doing it. I'm not sure. But anyway,
Yeah.
I'm glad you picked that example, because that was actually two of the problems that I had.
Okay, that was weird. Yeah.
So, okay, I think that's the tail end of my long list of questions.
I see Charlie Brown is having some serious issues here.
I know. Yeah, he sure was.
His sister Sarah is also a bit of a mess. Okay.
The whole crew is just really rough. Yeah.
Wow. Okay. Anything else that you think is weird or wacky?
Not that I wrote down.
Anybody else?
Well, I do have a question, Adrian. In the screen where it had gone, where you had went back and you're talking about the screen with the 100 ml times 10.
Oh, okay.
Yeah. The quantity.
Uh-huh.
Is that referring to? See, here it's different. Here, the quantity, you would say, okay, this is how much of it that they need. Okay,
Mm-hmm.
like let's say 5 EpiPens or what have you over a 30-day period. But in the previous screen, excuse me, how do you distinguish between I believe it was the quantity and the unit on there?
Well,
because on this it makes sense, but
uh-huh.
on the other screen, it wasn't very clear.
Yeah, so
or at least in my head, it wasn't.
Oh yeah, I don't think it's actually just in your head. Here, let's see. Oh, yeah, where I was doing create an application. It's really, it's about the format that you're using. So if you know somebody is using Humalog, you have to ask, if I can type, that is, you have to ask them, are you using a pen or a vial? And it should, very important word, it should come up to give you the option of how many units. You can say what this is. Okay, we know this is a vial. So if we can put in the quantity, well, if they're using, depending on how much they're using, which patients, of course, may not know, so you'll have to guesstimate.
Because sometimes it might just be like 2 vials per month or something, depending on the, whether it's the Humalog or whatchamacallit.
Wait,
and that's where I wasn't sure, were they referring to the actual number of vials or the ml of it all, if that makes sense.
Kind of. I think I got lost in there somewhere. But, let's see if we can rally the troops, shall we? So, I mean, with this, you should be able to choose a vial or mLs. And, if you're comfortable using an ml, you know that they're using 30 units 3 times a day, and you want to fish up the math, fantastic. But if the patient can only estimate that, I don't know, I use about 1 vial a month, then it's a little less precise, but still workable. So does that make sense? So if we're using 30 units 3 times a day, that means we're using 90 units. Goodness. Here, look at Adrian doing math. Woohoo! So it's 2,700 units, and there's 100 units in each ml. This might get furry. Yeah, so the quantity would be 27.
Okay, that's where Okay, that's
Let's
where,
let's just stick with vials, shall we?
mhm.
If you can guesstimate that they're using 12 vials a year, okay,
Uh-huh.
why not?
Okay, cool. That's what I wanted to know.
And ultimately, you can do that sort of fiddle diddle, and just look at good. If you're not sure how much something costs, just look at GoodRx. Which, have you seen GoodRx lately, folks?
No.
It's
I haven't.
gotten even better. I'm just saying.
Awesome.
So they've added more things. So you could use this to figure out how much do you think it might cost. Knowing that this is a discounted price, you might scroll down and go, oh, it should be something like this, so that you can guesstimate, did I get, the price of a carton? Did I get the price of a vial? So that what you're doing is matching up.
Okay.
Can I ask a question just related to med data? This is more a Matt Finley question. Why haven't we put in, or not med data, but GoodRx? Why don't we have that in the database for anybody to just say, hey, you can go to this website or download this app? I probably asked this question a million times before, and I always forget the answer.
It was in the website and then in the database for a while. And now at this point that I'm not working in the database, it's a good question. Adrian, do you remember the back and forth with that?
I don't know.
Because it had been in the database for a long time.
It was, and I don't know if I still have the ability to get in. Do we know if it is in there? Can someone look?
I'm checking. I'm logging in right now, just even to see if there's any notes or, history on it.
Well, let's see. It's been a while since I tried. Doesn't seem like I should have access to that.
Oh, you don't.
I am invalid, folks. Fair enough. There were a number of different, I think at last when I was leaving and they were talking about adding the discount cards in there, breaking them out instead of using that, they were talking about, having GoodRx in there, having the county card that's in there, and eliminating all the ones, because there were several that were in there from Toledo and I think from Stark County that were, when you really looked at their website, they were weird little shystery things that we shouldn't have had in there to begin with.
Right. Yeah, I know a bunch had come in with the inherited databases.
Yep.
Like you said, like Stark and Toledo, the stuff we got from other 2-on-1s.
But at this point, they had Needy Meds in there that had a discount card, which is decent, but GoodRx is much, much more useful. And they have the discount cards, of course, and they have the coupons. They have some of the national foundations. They have Medicare formularies that you can add that will tell you essentially what a particular insurance plan's preferred network pharmacy is, and or if it's cheaper to use their discount card or your Medicare insurance plan, which is pretty groovy.
I'm sending a transmittal to the resource team.
Oh, yay. Yeah, because I didn't see it in there, and I was like, this is a bummer because...
Yeah, it was in there for a long time. It was definitely in there, at one point.
I think it would be helpful for staff to be able to, at least tell people about it that have access to, the internet or a smartphone or who are, feel comfortable giving it a try.
Well, and it's something, of course, that the Medrefer folks or anybody can just simply text to someone, text the discount card from here or email it. Really easy. I don't honestly know if GoodRx was ever actually in the database. I know RX Outreach was.
Oh, maybe I'm thinking of one of the other ones. Yeah, maybe thinking of like RX Outreach or something.
Yeah, I don't remember it being in there.
I love this one with all of my heart. They have worked with a bunch of the different nonprofits, like Needy Meds, so and the National Foundation. So I certainly feel comfortable referring people to them regularly. But what else? Do you want to wander through some couple of scenarios just for fun, or what are you thinking?
I do.
Okay.
Let's walk through. Yeah.
This is Christy's world, so let's do it, Christy.
Oh, I mean, if anybody else has any suggestions, please. But I just want to make sure that I'm doing it right, and I think seeing you do it will really help me.
Yeah. So let's see. So I had sent a scenario out. So let's see here. It was the 44-year-old married Cleveland resident with a $3,100 gross monthly household income.
Mm-hmm.
They need a pedra and pen needles.
Mm-hmm.
They have medical mutual insurance through their employer, but they can't afford the $125 respective copayments. So that person is just presenting as, okay, I'm at $3,100. I've got 2 people in the home. I've got 44-year-old, and they have insurance coverage. So anybody want to guesstimate where we start with that?
I always start with GoodRx, but that's just me. That's so I can keep my.
Okay. Well, I think it's a good place to start. So they're looking for a Pedra Solo Star. And let's see what GoodRx, our good friend, has to offer. So Pedra comes up, shows that there is a coupon. See what the coupon says. Okay, so it is an Apedra no copay savings card. You can save up to $100 per prescription on out-of-pocket costs. And let's see, let's go here and see what we can do. Okay, so you sign up here, and it takes up to $100 off. Offer is not valid for patients if the prescriptions are paid for in any part by any federal or state-funded program. So if you're on Medicare, you can't use this. That goes across the board with any Medicare plan. But this person has private insurance. So hot diggity dog, I'm going to sign this person up and save them $100 off of their copay. Isn't that awesome?
Mm-hmm.
Yeah.
You sign them up directly on the site then?
Yeah.
Okay. Okay.
So I would just go through and ask the patient, you know, hey, I can enroll you online, or you can do it yourself, or you can call and do it over the phone. Which would you prefer? And, you know, 9 times out of 10, they say, well, you just do it. Okay, so I answer these questions. Typically, those questions are going to be followed usually with their birth date, their address, maybe an email. They don't have to have an actual email address. Almost always that you don't have to enter their email address. But you can always kind of make one up if they don't have one, or just create one if they're cool with that. But this takes 2 minutes. It'll come up with a discount card, you know, a copay discount card that you can either call in directly to the pharmacy, or just, you know, scan it and email it to the patient, or just give them the billing codes. I would normally just call it into the pharmacy and say, you know, making sure that they have a prescription on file, and say, oh, hey, pharmacist, I have some billing codes I'd like you to apply for whoever's medication. Can I give you the billing codes? Because the numbers are really small, so I don't want to try to fax it. And they'll say, okay, sure. You read them all the codes, the BIN number, the PCN, the group, all that good stuff. And I ask, can you run the prescription now using today's billing date, because you just now signed them up, and then it should go through for them. Takes all 2 minutes to do.
Okay.
Okay. And then, okay, so your copay, how much is your copay on your syringes? You said, you know, you're saying that's going to be something like $25. Well, that's still a lot. Well, if you're looking in, you know, ReferNet, you can see if there's an assistance program for diabetics that might help with that copay. Do they live in Cleveland or another area that offers copay help? If not, you know, a good default is, you know, how much would these little buggers cost if they went through like Walmart? And also store brands could be less expensive. This just kind of gives you an idea of, well, how much would these be for, you know, whatever type that they want. You know, obviously sometimes they're really specific about the gauge. So you have to kind of be cautious there. But the other thing is like RX outreach, which is also, of course, in Medrefer. No, in good grief, listen to me, is in Fernet. So RX outreach, the discount mail order pharmacy, they sell syringes at a reduced rate, among other things. Well, how much are they? Oh, it's 13 bucks for a box of 100. Oh, that's better than what I've been paying. But of course, they do these syringes, but they don't do pen needles. So if that person's using a Solo Star, that's not going to help them. But you can use this to figure out where else they might be cheaper, but you have to be careful that they're actually pen needles, not the full syringes. And Walmart sells, I think, 50 of them for 12 bucks.
Okay.
So that's a different option. So in order to log that, does everybody feel comfortable adding patients to this, to Meddata?
Yeah, I think well, at least for me, the adding patients is okay, but if you could roll through doing their medication part, that would be good.
Okay. No, I don't want to save. What is happening?
I haven't had the opportunity to, you know, add anyone or go into Meddata or Medrefer.
Okay.
So I'm kind of at a disadvantage right now.
Okay, so I mean, we can wander through that. It'll take all of 9 seconds, so let's do that. As soon as I close all these 700 windows. I'm confused here. Like, what is going on with my screen right now? Does anyone know? That is fascinating. Look, what happened here? This I've never seen in my whole life. Okay, well, we're just going to look at it all small. So, oh, here, instead of actually doing it, how about I actually say what I'm going to do? So you can get to adding a new patient a couple of different ways. You can do it here by going to patients. You can go to programs in your patients. Or heck, you can see if that person exists by using this quick tab. So if I'm going to look for Brown, Charlie's already in there, but I don't see Lucy. So I'm going to go ahead and add Lucy. So I can go back over here to patients, go to add a patient. I don't know that Lucy's name is actually Lucy Brown, but whatever. Patient ID in here, you'll see the kind of the instructions, the cheat sheet on, you know, how do I name a person in Meddata. So let's see here. Oh, yep. So someone who's uninsured, we call them un, because we can't export certain information that you record in Meddata, and one of those things is insurance. So I just coded their patient ID numbers to include one of these things, so I'll know what they are. So for this person, they have private insurance, so I'm going to name them P, at least I think I'm going to name them PI for private insurance. And then you just choose a 4-digit number. Why does it have to be 4? Well, you're less likely to get a duplicate if you've added 4 numbers instead. So you can use the last 4 digits of their phone number or whatever it is that you want it to be. But a couple of 4 digits, and then we're going to add Lucy and Lucy's address. Always have to enter the county, of course. All of those things you're going to need to have for the reporting. Same stuff you do essentially for your 211 callers, their age, their zip code, their ethnicity. That's something that you can ask or follow whichever protocol they're working with right now. But that's one thing that the county wants to know. And apparently I have really fat fingers because I can't type. Holy smokes. If you don't know somebody's birthday, you've only managed to get their age. Okay, well, then just put in 11. but at least you'll have their age. Gender. I find keeping marital status in there helpful just because that way it gives me an idea when I'm calling them back to ask, or when I'm asking them questions about income, if I know if they're married or not, it'll give me an idea of, oh, something didn't work well. Well, do I need to ask about a spouse's income or insurance status or something else? It just kind of helps me to get a clue. From here, that's that front screen. That's pretty much all you're going to need. If you've got an email address, super duper, use it. Citizen isn't often relevant, and I wouldn't ask someone on a regular basis. But if they present and say to you, oh yes, I'm a legal resident or I'm not a legal resident, then you're going to want to save that information. We don't report out on it, but a lot of the insurance or a lot of the drug companies won't serve someone who is undocumented, but they may serve a legal resident, but sometimes they just serve residents and they don't ask. And so you hit save. So this number didn't work because apparently it exists, someone else has it. You'll get that little button, and that means you just have to pick a different number. And again, you have to save. You can't go on to any of those other tabs, of course, until you've found them or save them. This is just their general information. Manufacturer IDs we don't use. Eligibility, it allegedly calculates your eligibility for different things. It's useless. Notes, in order to add a note, you have to click that Add New Record and then insert it. If you want it to be highlighted, you click that alert, whoops, and then hit Update. That way, when you get back to this page, the alert will show up once you refresh the screen. So it'll just come as when you first open somebody in Medrefer, this is the screen that you see first. And if you have this alert clicked, then it shows up here. Anyway, so then we go over to diagnoses. And of course, you have to add those. When we go back to this page, this is where we kind of use these are the categories that I've just kind of used over time, just to give you an idea of, hey, what is somebody being treated for, so we can kind of report out on that. So for this person, it's diabetes. Again, this thing about if you're using something for neuropathy in your feet that was caused as a part of diabetes, but it's not a blood sugar issue. You're not calling if someone's taking gabapentin because they have neuropathy in their feet because of their diabetes and poor circulation. You're labeling that medication as what it's being used to treat. It's not treating diabetes, it's treating nerve pain. So in that instance, you would call it pain or inflammation instead of diabetes. Does that make sense?
Yep.
Yep. Insurance. Hey, I still click these buttons even though I can't report out on it. It's just information that I may want to have when I talk to somebody later. Income, this person's income was, what did we say, $3,100 a month? Normally if it's somebody's information, like, oh, this one person's making $3,100 on their own, I'll put wherever it is appropriate here. If there's other income in the home, like she's making $3,100 and the spouse is making $1,200, I will divvy it up that way, just because it may be useful information to you later. But again, you have to hit Update All. And that's kind of all the excitement that there is. So with this person, if I'm sending them an application, or I'm enrolling them in the copay discount card, that's not going to be in here. So you kind of have to bastardize it as we have over the years and go to Add Provided Med. And then choose your patient, Ms. Brown. Diagnosis is diabetes. Drug name, well, I have, if you may remember, seeing in here somewhere, oh, here. What I've coded these as, when it's a discount, not a drug company application, we need to use one of these codes, so it makes good sense. We can then add those up together and export it so we can create some sort of a report. It's also important if this person were to call back in a month and say, hey, I have this problem. I can't afford my Pedra copay. You can say, oh, I found you in here. It looks like we had sent you one of those before. And they say, oh, well, I want to do it again. Well, you actually already signed up, so you have to use the same card. And then you would just give them the 800 number to call to get the document, or just have them go to the pharmacy and say, hey, rebill it like you did last month. You just wouldn't want to try to enroll somebody again in the same program. So here we're using, let's see, copay. This is a manufacturer copay discount. So I'm just putting in copay. And this person is going to be getting $100 off. They're going to be able to do that up to a year. So I'm calling it 360 days, and it's $1,200, and I'm going to hit save. And that's it. And we'll go back and find that person. So see how this comes up as this alert, and it's in red, so it's something that's noticeable. So again, that note that you want to put in, if you want it to be a big deal, it'll show up here. And then here's your history. So now when Matt or whoever exports that data, you'll be able to include this. The crummy part is when you add that field, if you don't click the diagnosis, it doesn't stay there. Anyway, questions about that? I hear none.
Nope.
Cool. Hot diggity dog. So let's see. The 83-year-old Beechwood resident with a $2,800 gross monthly income needs Ventolin, Advair, and ipratropium solution. She's struggling to pay a copayment of $250 each month through her SilverScript Plus Part D plan. Now what? Okay, I'll do it. Go ahead.
No, like I said, I always start with GoodRx. I mean, is there a better way to do it? Like, I kind of walk through each, like, I'll do GoodRx first to see what they have, and then I'll look at whatever the other one is that I didn't write down there.
That is in my opinion, that is a perfectly reasonable response. It kind of will give you a lay of the land of, what are my options here. But just thinking about this one, so her income is $2,800 a month in gross, and it's a single person. So that means she doesn't qualify for extra help through Medicare, right?
Right.
Because the income guidelines for that are what?
I wrote it down here.
More than $2,800?
18,000 in 2018.
Yeah, so 150% of federal poverty. So she's not going to be able to get that. So that's not a go. She has a copay that's $250. So if we were to pull her up here and say, okay, she needs Ventolin, HFA. So something that's important to ask her is, okay, so if it is Ventolin, we found that here, what is she using her Ventolin to treat? So with this program, let's see, what can we see? At or below 250% of federal poverty. And what's 250% of federal poverty for a single person?
What did you say? 130?
What is her income was $2,800 a month for a single person.
I didn't calculate it. I just have that she's above it written down in my notes.
Yeah.
So yeah, exactly. So poverty for a single person is about $1,000. So she's at 2,800. So she's over 250. So she can't use this program. She's over the income. So let's see what else is in here. Oh, the HealthWell Foundation. Oh, that's exciting. HealthWell Foundation may have insurance. Helps those with Part D. Okay, must be a medically appropriate diagnosis or condition, blah, blah, blah. Okay, well, we'll look at that one in a second. Patient Access Network Foundation. Income guidelines 400% to 500%. Well, looks like she could fit in there. This is a hospital reimbursement program, so that we don't care about. Okay, so for, let's see, the HealthWell Foundation. So she's using this medication for asthma, perhaps? Open funds. So this is the HealthWell Foundation and their open funds. I don't see asthma in here. I don't see anything related to breathing disorders. Okay, so closed funds, let's see if they got there. Oh, asthma's closed. All right, so this one's not gonna work for her. So what was the other one, the Patient Access Network?
Mm-hmm.
So Patient Access Network, blah, blah, blah. Okay, so let's see what these kids have got. Okay, look, they're helping with asthma. Okay, so let's see what the criteria are here. So sometimes it's for Medicare enrollees only, sometimes it's for those with private insurance, sometimes you have to have a minimum copay. So what's your deal? Okay, so they will help a patient with asthma. They are currently accepting patients. They have to have a Medicare insurance. They have to be under 400% of FPL, which she is. Has to be on the list of medications that's covered. Ugh, okay, well, let's see here. Ventolin. So Ventolin's here. What else did she need? She also needed Advair. That's here too. That's exciting. And then ipratropium. Well, look at that. So it looks like she could get up to $250 worth of help with her asthma medications by calling this phone number or applying online. And they'll help with up to $1,400 a year. And since we're in December, she really only needs a little bit of cash, so that should work just fine. Questions?
No.
Okay, so when we go ahead and we add her, we're going to assume that she's also Lucy Brown. So we're going to add her provided med. And we're going to go back to have Ms. Brown here. Lucy. Well, we don't have her diagnosis of asthma, so we'll have to add that later. And this is a foundation, so we're going to call it that, I think. Is that what we called it? I forget. Foundation. Look, there it is. I don't specify the name of the foundation. I don't care, but it would be really great to be able to say, okay, this is whoever it is. So for this particular lady, if she had called back in October, we would have been able to say that, oh, we're going to help you for the last 3 months, and this would have been 750 clams. But because we're in December, she's only going to get $250, so that's all I'm adding. So I've got the name of the drug, I've got the AWP value, I can save that. And then I'm going to go over to patient profile so I can add the diagnosis. And then I have to go back. So I'm going to add new diagnosis. And these we call breathing disorders because we don't differentiate one with the other. Honestly, it would be helpful to say asthma because you may need to know that she's got asthma. Put that in there. Won't make any difference when you go to export the information or when Finley's going to create the reporting because you started with the word that he's going to sort by. So foundation, select diagnosis, breathing, asthma, save, and close, save and new. If you hit save and close, then you're done. What you can or probably should do is break these out. I don't know how much her copays were. For her, you could say, okay, well, her copay total is $250. Well, how much is each one individually? You could add a separate foundation copay for each particular one, but she's a made-up person, and I don't know that information. And now it lives in there. So that's that one. Any questions?
Mm-mm.
Nope. Okay, so the other one is oh, go ahead.
Oh, I just said no. I don't have any questions.
All right, Molly, thank you for your commentary. So a 19-year-old single Euclid resident with $1,000 gross monthly household income needs to get azithromycin 250, 6 of them, otherwise known as a Z-Pack. He thought he had Medicaid. Now he needs to reapply because he went to go get it, and they said it's not covered. Holy smokes. 19-year-old Euclid resident, $1,000 gross monthly income. Okay, so, well, I guess we can start with needy meds and see what they say. And azithromycin. How do you spell that?
AZITHROMYCIN.
Yeah, girl. Okay, so let's see what azithromycin can get us. Azithromycin, holy smokes, there's all kinds of stuff. Oral suspension, azithromycin tablet. Okay, this just gives you more information. This is where there's a $4 drug program somewhere else in the world, but not here. Should go to Sam's Club. Which that wonderful thing about Sam's Club, where if you don't have a membership, you can still go there and get your prescriptions, but you actually have to be a Sam's Club Plus member. Did everybody already know that?
No.
Yeah, you can go in. So if you walk in the door and they ask you for that ID card,
Yeah.
you just say, oh, I'm going to the pharmacy. And then you just go to the pharmacy. You can be anybody and go to Sam's Club and get your medications filled.
Huh.
Yeah.
I did not know that.
And usually their prices are comparable to Walmart, sometimes better. Anywho, so tablets, doesn't look like there's anything here. So maybe we go back to my old friend and just get an idea. Like, okay, so how much did they charge you for the azithromycin? Okay, you were going to where? Probably Walgreens or some other mess. Let's see. So they have it pulled up here at a Z-Pack. Some people won't know if it's a Z-Pack, so just how many tablets is it? Oh, it's 6. It's 1 Z-Pack. Super duper. Okay, so here, let me add in. Sorry, the site looks a little different than it did the last time I was here. Where can I put my location? Whoops. Sorry, I'm distracted by my cat who's making circles around me at this moment. I'm a little freaked out by that. Okay. So set location. I am 441. Hello. This is what happens when you're impatient. Okay, so in 44115, the medication, this is an online pharmacy. Walgreens, it's $16. Okay, well, if it was $16, do you think that that's something that you could afford? I don't know, maybe. Okay, well, so the options are you could use this at Walgreens and it would be $16. Or you would then say, okay, well, where did you get that prescription? It was from an emergency room or oh, it was prescribed at Metro Health. Well, did you know that they have a special pharmacy that you can buy medications at a discount depending on which Metro Health that you went to? Oh, you went to the one that's on Broadway. Have you called their pharmacy yet? Here, let me put you on hold and I'll call the pharmacy and get the $340B price for you. And that may make it a lot less expensive. But so if the patient thinks that they can do 16 bucks, great. Or if they're in Refer, there is a list. It does show whether or not they offer discounts for that particular Metro Health location. You'll only see that in Metro Health, or you could refer them to someone like one of the community clinics that may help them to access that medication by doing presumptive enrollment in Medicaid. You may have seen there's an 866 number for the Medicaid hotline now where they can do their renewal over the phone, and they can activate it immediately unless they need, some specific documentation. Are you guys familiar with that thing?
Ooh, no.
Yeah, I think maybe when I was leaving or right after I left, I think I had given the information to, I don't know, Martha probably, but it's an 866 number, and it was already activated, I think, in Stark. But you can do your application for Medicaid benefits, for renewals, for SNAP over the phone, and it's actually, you're talking to actual caseworkers, and they can activate a case right away. They can do presumptive right away, unless, hey, we told you we needed this specific documentation, and no, I won't enroll you over the phone. You have to send the documentation first. But I think it was 40% of the people that called to apply over the phone were actually activated immediately. So it's pretty amazeballs. And I've gotten really good feedback from the Stark County clinics that I've talked to that is actually working very well for them. But it is statewide.
Good. Good to know.
Hot diggity dog. So those are some of the examples that I had. I think, Molly, you had sent some other ones. Do you want to go through some other ones, or are there other questions, or are you all just done?
I think I'm okay with this. I may have to send you a question or two down the road, though. Is that okay?
Absolutely. You can always send me an email or just text me. That's the easiest. Honestly, texting me is probably easiest, or just text me and say, I sent you an email, and then away I'll know where it is. But you can use the UW Stark one, because that one I look at more certainly than the Kent one.
Okay.
Anything else? Finley, do you have anything about the reporting piece of it, or?
No, it was just good to see you walk through that. I'm looking for this, what you guys were just talking about. Again, like, since I've been, in accountable health communities mode now for months, I have no idea what's going on in the database.
Well, I think I mean, last I looked, it was still under the, Medicaid information counseling.
Oh, okay. Yeah, I just want to make sure that that's sitting in there somewhere, that people are aware of it and can find it, because it sounds cool.
Oh, here, I'll be a bad person and ask you this. Oh gosh, where is it? The online, the website, where is it here? This is still up. And I had asked Connie about this, and I don't know why it's still up.
They had wanted that up. Does she not want it up anymore? Originally, we had.
Yeah, they don't believe that it's up. They think it's down. They don't think any of this is accessible. And I think their concern was they weren't sure if this was current, if this is, because I thought it was updated in real time, but I don't know. Because
I feel like we looked into this for her, and it is updating. And then because of that, she told us then to keep it up. Because of the number of agencies, I did a web report on it about how many local agencies were still accessing it. And there were enough that their United Way had said, well, we don't want to just take it down then without meeting with some of those agencies first. There was an issue.
Can you, when did you guys actually have that conversation? Like recently?
Recent. Well, I mean, maybe last month. Maybe in October, November, because there was something going on where the site wasn't updating the thing that says when stuff was last updated.
Okay.
So, because what I did was I checked stuff that was updated like the day it came up, was like what changes were made today, and I checked on that site and saw that they had been reflected, but the site was like, this hasn't been updated since 2015. But when I was looking in Refer, I was like, well, no, this was updated today, and the information is correct on the website.
It is.
And then, and so then I had been asked to run some web reports, which I did, from Refer's web thing to see like, are people still using this? And then we found like there were, I think, like 300 like agencies or something that had accessed it recently, and so they were like, oh.
Well, and part of my concern is that they're trying to create, Stark Mar, the Mental Health and Addiction Board, is trying to create an online tool, and they want to pull some of the information from 211. And
I mean, the only issue, and they're aware of this, is that this is only the STAR access site.
Mm-hmm.
So like statewide resources are not going to show up here anymore because those sit in CUI.
Okay, so I'm not sure if this is active, only because the last time I checked, Access Health Stark County, because they don't do this anymore.
Mm-hmm.
Because I thought they had, is this still in the actual refer now? Because this they don't do anymore.
Which one is that?
The Affordable Care Act Information Counseling.
Oh, well, so now, yeah. Well, so now it looks like this. Yeah, so now it's looking like at some point this stopped because, yeah, you're right. That is not in Refer anymore.
And there's other ones that aren't coming up here.
Yeah, and that we have.
So
where is that? Because everyone was trying to figure out where that page was linked from still.
I just Googled 211 Stark County, and this was like the second thing that came up after United Way's website. So that was a little concerning.
But it's not linked on their website anymore.
It's not, no.
Okay. No, that's what I wanted to confirm.
So anybody have any other Medrefer questions?
I don't. I think I have everything covered that I can think of right now.
Hot diggity dog.
Yeah.
Okay. Yeah, it doesn't look like that's current. Okay.
Yeah, I'll call Connie about it and see if they're comfortable just pulling it down.
I think Connie honestly thinks that it's not there.
I mean, I'd say pull it down I don't even know where it like is sitting or housed at this point. So.
Okay.
But that's probably a Refer thing to figure out.
And if you wouldn't mind circling back with me, because right now Connie isn't very responsive on 211 issues. So yeah, if you don't get a response from her or you get like blurry stuff, let me know and I can ask.
Yeah, no, thanks. I appreciate that. Yeah, but I'll reach out to her tomorrow.
Okay, good. I didn't say that.
Refer.
It's recorded. Anyway. All right, guys. Well, it was a pleasure to hear all your little voices.
All right. Thank you, Adrian. This was helpful.
Thanks.
Good. Make some noise if I can help.
Great deal.
All right, now go have some fun, will you?
Okay, bye, everybody. I'm going to go ahead and end this.
All right.
End this misery. Got it.
All right, bye.
Kiddo.
Bye.